So the choice of the therapy, assuming this patient was a BRAF wild type, so didn't have a mutation in BRAF, I think it's very appropriate to start the patient on FOLFOX bevacizumab. An alternative to that would be FOLFIRI bevacizumab. They're equivalent. There are some hints that FOLFIRI may be a little bit better, but overall I think it's a wash, meaning whether it's FOLFOX or FOLFIRI, that's a chemotherapy backbone that's acceptable in this patient, especially with a BRAF wild type tumor. Now comes the whole issue of sidedness and the decision of how to use biologics. So we have right-sided tumors, left-sided tumors. Now we understand that they behave very differently. They're driven by different genetics. They do have different genetic profiles. And those on the right side seems to be generally non-responsive to EGFR inhibitors. Those on the left side may have a little bit better outcome with EGFR inhibitors versus VEGF inhibitors. So in this patient, a right-sided tumor, it would make a lot of sense to start the patient on bevacizumab as the biologic plus the chemotherapeutic backbone. If this patient had a left-sided tumor, personally I would still have started the patient on bevacizumab. However, I would have an earlier onset of use for EGFR inhibitors, meaning second line rather than in later lines of therapy for the patient with left-sided tumor. So in all instances on the right side where EGFR inhibitors seem to actually have less activity, it would make tremendous sense to start the patient on a VEGF inhibitor, i.e. bevacizumab with chemotherapy. So I think the starting point, again assuming that this was a BRAF wild-type tumor, the starting point makes a lot of sense for this patient. Now, I think the other important question is, and this is a question that arises a lot, of course, now we understand that when cancer spreads to the liver only from the colon, it behaves a little bit differently. It's typically associated with better outcomes overall, but also we address these recurrences a little bit differently than someone with widely metastatic disease. Why is this important? Because we know that for some patients who have liver-limited disease, that we can cure them if we are actually if we're able to get them to surgery, to surgical resection. Now, unfortunately, if you take the whole community at large, there's only 5% of those patients who will recur just in the liver and with few lesions located in just few lobes, one, maybe two, lobes with isolated lesions. Those patients can go to surgery. They need to be referred to a multidisciplinary program. The surgeon and the medical oncologist and the radiation oncologist and intervention radiologist, they all have to come together and decide, if this gets optimized. For the majority of the patients with liver-only disease, surgery ends up being not an option. But everyone should be considered for surgery. Everyone with liver-limited disease have to be considered for surgery by a liver-specific surgeon. Like I said, most of them will not go to surgery, but they have to be considered because we know we can cure those patients. Other than surgery, there are other liver-directed approaches that we can consider as part of our treatment options. And that essentially includes liver-directed therapies such as SIR-spheres, which certainly have some applications. The question is, when do we consider the application of SIR-spheres in the treatment of metastatic colorectal cancer limited to the liver? There was a large study that looked essentially at the role of adding SIR-spheres earlier on in those patients, so similar to this case. It didn't meet its primary endpoint. In other words, progression-free survival was not much different between the patients who get the SIR-spheres added and those who are not. The only difference was that the disease in the liver get delayed in terms of progression, but we have no clue right now whether this will affect survival or not, which is the ultimate measure. This will be coming. We will understand a little bit more about survival soon. At this point of time, I don't think I can recommend SIR-spheres in the earlier stages, and we leave those typically to second or third line if the disease is still limited in the liver and if we start running out of options. So MSI testing, as I alluded to, is now mandatory for all patients with colon cancer, regardless of the stage. In this particular patient, I think it's a must. From the first day you meet the patient, it's even more of a must when you see the patient with metastatic disease. Very important because it tells us about two things. One, it may link us to a family history, and that's important for the patient and their families. But two, we know that tumors that have high MSI are exquisitely sensitive to the effects of immune therapies. In other words, when those patients have MSI high tumors, they tend to have a lot of mutations. So they are what we call hypermutated. So they have these antigens that are overexpressed, and they make them very inflammatory and very susceptible to the effects of immune therapy. For those patients, immune therapy becomes very important. Now the question, of course, if I have this patient coming to me from day one, would I, with MSI high tumors, would I consider pembrolizumab or nivolumab in the first line rather than chemotherapy? That question is being answered right now by a clinical trial, a national international trial that's looking at the role of immune therapy first versus chemotherapy. But at some point, that patient will definitely need immune therapy as part of the treatment. In fact, the NCCN guidelines just changed in the refractory setting, the guidelines to add MSI high tumors. Those patients would receive pembrolizumab or nivolumab based on the presence of MSI high expression. Now, in my own practice, I actually try to individualize, and for many patients, outside of a clinical trial, I would consider bringing immune therapy to the first line. MSI high status in stage 4 colon cancer is an indicator of bad prognosis. So these patients can actually do very bad very quickly and may never have the opportunity to go on immune therapy. So I tend to favor bringing immune therapy a little bit closer to either first line or second line in those patients. We've seen some remarkable responses in our patients. I mean, for some patients who blew through chemotherapy had just remarkable responses, and not that the depth of response is remarkable on its own, but also the durability of the response is pretty remarkable as well. So those patients respond and will continue to responding. Unfortunately, there's still a subset of patients that doesn't seem to respond at all to treatment, to immune therapy treatment despite MSI high, and we're figuring out strategies to essentially expand that advantage to most patients.